Good afternoon, everyone. Now we will discuss the surgical management of cervical disc prolapse or herniation or degeneration only. Now we consider surgical treatment if the initial conservative management fails, or if there is a significant neurological deficit which is threatening the motor power of the upper extremities or threatening the spinal cord, leading to partial paralysis or consequences like loss of balance, etc. Now, the medical literature or spinal medical literature suggests that surgical treatment is the only effective way of definitive treatment for cervical disc pathology. So therefore, we consider conservative management as a mainstay, because no one would like to have a surgery if he can avoid it, but we always believe that surgical management, whenever indicated, is the ultimate choice. Now, surgical treatment varies. Obviously, the technique has improved over the last 20 years. I remember when we were in early training stages, we used to do anterior cervical discectomy with using a block of bone taken from the iliac crest to allow fusion, and we didn't fuse the spine at that time. We didn't put any metal work there. But obviously, this proven to be an inferior technique with time, and now surgeons try to secure the spine with some cages, plate, and screws. And also the latest advances in cervical disc treatment is after decompressing the spinal cord or nerve roots and excising the whole disc, we could use an artificial disc replacement, which is currently, and in my opinion, is the best choice, as it saves time for the patient and avoid failure of fusion rate and many other advantages. Now, there is some techniques which been recommended also in certain cases, like posterior nerve root decompression or foraminotomy, where the surgeon can only remove the pressure from the nerve coming out from the spine down to the arm. But basically, this is considered as a treatment for radiculopathy only and does not treat the neck pain itself or axial neck pain, and therefore I believe it is not the ultimate choice for one spot solution for the whole problem. Now, what judge which procedure we have to have? Obviously, this is has to be discussed with the patient in full details and analysis of which level we are doing, any contraindication to one procedure on the other, how many levels we are doing. Some financial restraint can also affect the decision, and it is basically also the preference of the surgeon and whatever technique he feels he better to do himself with that particular patient. So I think my preferred choice is basically artificial disc replacement, but it may not be for my other colleagues. However, this is something need to be discussed in full details during the consultation prior to surgery to decide about the best way to go.